The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Okay, so hi guys! Isang magandang afternoon sa inyong lahat. So welcome to our main lecture of pharmacology. No? So I am Dr. Imran Rodriguez. You can call me Doc Im for short. I will be with Dr. Gabby Flores for this set of lectures under pharmacology. Now I know na and we know na mahirap ang pharma to begin with, no? Madaming kailangang aralin, madaming kailangang i-memorize, yung mga mechanism of actions, yung mga indications, at saka yung ating mga side effects, no? But we hope, no, goal natin sa lecture na to is for us to be able to simplify, no, yung mga bagay-bagay para hindi kayo ma-overwhelm and parang to be able to guide you kung ano dapat yung mga kailangan nating i-memorize at ano yung mga kailangan nating intindihin para mas mapadali yung buhay natin sa pharma, no? So we hope na this will be a fun lecture for you all, no? Okay, so without further ado, let's start, no, with our pharmacology lecture. Okay, so now let's go to the first topic, which is your basic pharmacology, no? So as we know, no, our basic pharmacology revolves around the study of our drugs. So your drugs are known to be any substance that cause any change dun sa biological system ng isang organism, no? And the main principles that we have to discuss under the basic pharmacology would be your pharmacodynamics and your pharmacokinetics. Pag sinabi nating pharmacodynamics, ito revolves around the study of how what the drug does to the body. Now, what the drug does to the body. D and D for drug and dynamics. Okay, para mas madali nyo matandaan. So dito sa pharmacodynamics, ang pinag-uusapan dito is ano yung mga effect ng drug sa katawan. Pinapataas ba niya yung heart rate? Ginagawa ba niyang vinavasodilate ka ba niya? Or any other clinical effects. So dito pinag-aralan yon sa ating pharmacodynamics. But when we talk about pharmacokinetics, pharmacokinetics naman is what the body, okay, or yung katawan ninyo, no? Katawan, what does it do to the drug? Okay, what does it do to the drug? So K, encircle K, K for katawan, no? Katawan, what does it do to the drug? Okay? So dito sa pharmacokinetics, ang pinag-uusapan is ano yung ginagawa ng katawan ko para ma-absorb yung gamot, or meron ba siyang effect sa paano niya ini-eliminate yung gamot, or paano niya mine-metabolize yung gamot. So ang pinag-uusapan dito basically would be your ADME, no? Absorption, no, distribution, metabolism, and your excretion. So those are the topics that we will be discussing under your pharmacokinetics. Okay? So let's now first discuss yung pharmacodynamics, no? Under your pharmacodynamics, we have to know yung mga different response curves. Pag sinabi natin response curves, no? We have two. We have your graded dose response curve, and next we also have your quantal dose response curve, no? In your quantal dose response curves, these are curves that show how the drug what are the effects of the body to the drug, no? Your graded dose response curve mainly tell us, no, what is the effect of a certain drug to the clinical aspect, or a certain clinical parameter. Ang keyword niyo dyan ay yung clinical, no? What is the clinical effect of a certain drug? So, sorry, hinubo pa. Ayan, so clinical effect. So, di ba, for example, we have this drug, no? Dito sa picture na to. If you increase the dose from 0.5 to 5, what is the clinical effect of increasing that from a certain dose to a higher dose to the body? Anong maging effect nun to the body? Naintindihan ba? Tataas ba yung heart rate? No? Okay? Or gaano kataas yung pagtaas ng heart rate? Naintindihan. So that's your graded dose response curve. When we talk about quantal dose response curve naman, This is a certain graph that tells us what is the effect to a certain population. No? What is the effect to a certain population? For example, if we increase the certain dose of a drug, no, gaano kadaming tao sa isang populasyon yung magkakaroon ng ganitong effect, no? Gaano kadami sa populasyon yung magi-increase yung heart rate? Gaano kadami yung bababa yung blood pressure? Ganon. Okay, that's your quantal dose response. Again, quantal, population. You think about population. Okay? So furthermore, let's discuss the different some important pharmacodynamic terms, no, that you have to remember. We have your efficacy and your potency. Pag sinabi nating efficacy, guys, no? Pag sinabi nating efficacy, it is the maximal effect that you can achieve, no? For example, if kunwari ako ay isang drug, no? If I stimulate the certain receptor, no? Ano yung maximal effect na kayang ma-achieve ng receptor na yon? That is your efficacy. Pag sinabing potency, no? It is the certain amount of drug that ano yung amount of the drug that can achieve a certain effect, no? Usually it's in terms, no? Pag sinabing potency, they are usually parang defined as the effect that reaches a 50% of the total effect, no? Ilang amount ng drug, ano yung concentration ng drug that will give us a 50% of the maximal effect. So it's usually in terms of that. So kaya makita niyo pag potency studies, no, you will see your EC50, no, your TD50. Your EC50 is your effective concentration at 50%, no? And also your TD50, yan yung toxic dose, no? Or toxic dose at 50%, no? So those are the terms that you have to remember. Again, potency, no? Usually they are defined in the term pag nakita niyo 50-50, no? Ilang yung concentration to reach a 50% of a certain effect, okay? So those are important terms that you have to remember, no? So next, there's also in terms of potency, no? In terms of your not potency, I mean, in terms of your response curve, meron tayong term na tinatawag na therapeutic index. And you can measure the therapeutic index of a certain drug by getting the ratio between your TD50 and your ED50. Now, certain drugs have narrow therapeutic index. Alam natin na marami tayong naririnig na mga ganyan. No? We have your warfarin, di ba? Your digoxin, no? Yung lithium, yung mga anticonvulsants natin, no? They have narrow therapeutic index. Ano bang ibig sabihin ng narrow therapeutic index, no? Pag sinabing narrow therapeutic index, for example, if a drug, itong yellow, no, has narrow therapeutic index, malapit yung ED50 niya or yung effective concentration, meaning yun yung dose at which, 'di ba, ang ED50 is the effective dose, no? Effective dose at which 50% of the efficacy will be reached, no? Ibig sabihin, gaano kadami yung drug na kailangan mong ibigay para magkaroon ka ng 50% na effect, no? Yun yung ED50, no? Explain ko muna yung TD50. Yung TD50 naman is the drug, okay? Is the amount of the drug or concentration of the drug that will reach a certain toxic level. Now, your therapeutic index is the ratio between those two. If the difference between those two is wider, no? Ang drug will be safer to use because mas madami kang levels of doses na paglalaruan. Kasi hindi ka matatakot na, ay, konting taas ko lang, toxic na siya. Ay, konting baba ko lang, wala na siyang effect. Diba? So, kailangan nandun kasi sa gitna. But for certain drugs, such as those that I've mentioned a while ago, they have very narrow therapeutic index. And what happens is that you have a very small window for you to play with. No? Bababaan mo lang konti yung certain amount, yung dose ng drug, wala na siyang effect. Malagpasan or mataasan mo lang ng onte yung amount ng drug na ibigay mo, magiging toxic na siya. So you have to be careful for drugs that have very narrow therapeutic indices, no? So yun yung definition ng therapeutic index. So okay. So let's go further yung mga different topics under pharmacodynamics, no? So kanina na-discuss natin yung mga different response curve, no? O dito sa picture na to, as you can see, you have your dose on the x-axis and the activity in the y-axis, no? Likely it's clinical effect or clinical activity. Ano kayang dose response curve to? Applying lang what you learned earlier. This can be a graded dose response curve, no? So tignan natin ngayon kung ano yung mga different types of pharmacologic terms in terms of yung effect niya dun sa response curve, no? So first, let's discuss kung ano yung constitutive activity. Yung constitutive activity, it's a certain amount of activity that a certain receptor does, no? Parang yun yung baseline na ginagawa niya, no? Parang siyang at rest, quote unquote, no? Parang at rest. What's the constitutive activity? For example, kaya lang niyang baseline itong ganitong certain heart rate, no? Meron siyang certain stimulus na in-release to achieve this baseline na certain heart rate. But if you give, for example, a certain drug that will increase the heart rate to the maximum capacity of that receptor, no? You call that a full agonist, no? So full agonist. Pag sinabing not full, syempre, full, not full, it's a partial agonist. Ibig sabihin lang ng partial agonist ay hindi mo kaya ma-achieve yung maximal efficacy na kayang i-achieve ng receptor na iyon. Okay? Pinaka-important na kailangan tandaan for partial agonists is when you mix them with your full agonist, they act as antagonist. Okay? Don't forget that. Partial agonist in the presence of a full agonist will act as an antagonist. Okay, now speaking of antagonists, no? Your antagonist will bind to a receptor and ang gagawin lang niya is i-maintain lang niya yung constitutive activity, the baseline capacity of that receptor nang walang nakadikit. Again, ang constitutive activity, di ba, yun yung kaya niyang i-achieve na activity nang walang nakadikit na mga drug or substances. So, yung antagonist, pag nag-bind siya doon, walang nangyayari. Neutral, okay? Neutral constitutive, nandun lang siya sa baseline. Pag sinabing inverse agonist, it does the opposite. So ang nangyayari doon ay nagkakaroon ng pagbaba doon sa constitutive activity. For example, it reverses, no? It causes a decrease in the it causes bradycardia, ganyan. It causes a decrease in the heart rate. So that can be an inverse agonist, okay? So next. Teka lang, nawala yung ako. Okay, so furthermore, let's discuss the different types of your agonist and antagonist kasi lagi itong dinidiscuss, no? Kanina sabi natin, agonist, we have your full and your partial. And ano ang tatandaan natin pag partial agonist? In the presence of your full agonist, anong nangyayari sa kanya? They act as antagonists. Now, speaking of antagonist, no? Your antagonist. Okay, sorry na putol. So nawala ng connection. So going back, no, let's compare your physiologic antagonist with your pharmacologic antagonist. Kung si physiologic antagonist kanina, no, ang ginagawa niya different receptors, si pharmacologic, the keyword is same receptor. Kung kanina example natin, 'di ba, histamine, no? And your epinephrine, ngayon, try natin. Histamine ulit. Kanino siya magbabind na receptor? Histamine receptor. Ang pharmacologic antagonist ni histamine will be antihistamines. No, you give your antihistamines, your cetirizine, yung mga ganyan, etc. na mga different drugs natin. So again, ang difference nila, same receptor yung dinidikitan kapag pharmacologic antagonism. So kunwari, meron kang histamine, you give antihistamine. Okay? So that is the difference between the two. Pag chemical antagonism naman, yung mga chemical antagonists natin, ito, they act directly on the they act directly on the certain substance or drug. So for example, in the body, dito sa tiyan natin, no, meron acidic contents, mababa yung pH. You give your maalox or for example your aluminum and magnesium hydroxide, 'di ba? Basic yung pH nung dalawang 'yon, 'di ba? When you put them in the stomach, put them talaga. When you take these kinds of drugs, no? Pagpunta nila doon, they have opposite pH. Ang ginagawa niya, ni-neutralize nila yung isa't isa. So for example, si protamine sulfate and your heparin, they also neutralize each other, no? They don't bind to a receptor kumpara ninyo doon sa physiologic and your pharmacologic. Now, let's further discuss our pharmacologic antagonism. Pag pharmacologic antagonism, meron tayong dalawang types. You have your competitive and your non-competitive. Pag sinabing competitive inhibition, no, ang keyword nyo dyan would be, okay, reversible, no? Reversible. Pag sinabing reversible, madali lang yan intindihin. Kaya mo siyang patalsikin doon sa receptor. So kunwari, ito yung receptor mo, ito yung drug mo. Pag kumabit siya doon, madali siyang maalis doon, no? Kaya siyang paalisin doon nung kapag ka nagbigay ka ng other antidotes or another certain amount of drug, no? Pag sinabing non-competitive naman, ang keyword dyan ay irreversible. Kahit na ibig sabihin, pag dumikit yung drug doon sa certain receptor, hindi mo na siya maalis doon. Permanent yung pagkakadikit niya doon. Now, put those into mind when we discuss these two, no? Kunwari, pag sinabi natin competitive antagonism, no? Pag sinabing competitive antagonism, kaya mong taasan yung dose nung drug mo, no? Para mapatalsik mo si drug, yung antagonist mo dun sa receptor. So kunwari ito siya, no? Ito yung drug mo, ito yung antagonist mo, no? Kaya mong magbigay ng mas madaming drug, no? Yan, damihan mo lang yung certain amount of drug, no? Para mapatalsik mo yung nandoon sa receptor, no? Na antagonist. So ang nangyayari nun, kung kunwari, basically ito, tingnan niyo yung yung graph, no? Basically kung ito yung certain, okay, ito yung certain activity ng certain drug, no? Ang nangyari, no? Para ma-achieve mo yung 100% ulit, kailangan mong damihan yung dose, no? Kailangan mong dagdagan, no? Yung inyong drug, no? Para mapatalsik mo si antagonist mo dito. And ang nangyayari doon, no? Kaya mo pa rin ma-achieve yung maximal dose, no? As seen dun, ito, gawin kong blue, ha? So, kaya mo pa rin ma-achieve yung maximal dose, no? Or efficacy, maximal efficacy by just giving an additional amount of the reversing agent, no? Pero ang nangyayari noon, 'di ba? Sabi ko, 'di ba, dinagdagan mo yung number of dose, no? Tinaasan mo yung dose para mapatalsik mo siya. Ang nangyayari noon, yung potency mo ay bumababa. Okay? Bumababa yung potency mo. Bakit? Bumababa yung potency dahil kinailangan mo ng mas mataas na concentration ng drug para ma-achieve lang yung 50%. Nagets ba? Dahil meron kang antagonist. So that's called as your competitive antagonism. Keep in mind na pag napatalsik mo si drug, maa-achieve mo si 100%. Naintindihan ba yon? So again, pag napatalsik mo si antagonist, kaya mo pa rin ma-achieve si 100%, pero kinakailangan mo magbigay ng mas madaming effort. Effort means parang drug, no? Kunwari, no? Kailangan mo magbigay ng mas madaming drug para lang ma-achieve yung certain efficacy, no? Kaya ang nangyari nun, bumababa yung potency. In summary, kapag competitive antagonism, same pa rin yung efficacy, yung potency yung bumaba. Okay? Compare natin siya sa non-competitive or irreversible antagonism. Kunwari, ito yung certain receptor mo. Okay? Ito yung certain antagonist mo. Sabi natin kapag irreversible antagonism, no, meron siyang permanent linkaging, new term, permanent binding dun sa receptor mo, no? Ngayon, kahit na damihan mo si drug A, no? Kahit pa damihan mo pa yung drug A na yan, hindi nila mapapatalsik si antagonist, no? Ang nangyayari nito, ma-achieve mo pa ba yung maximum effect, no? In stimulating the receptor? No na. Hence, your efficacy will decrease. Nagigets ba? Again, yun yung difference nila. Competitive, same efficacy will be reached kasi kaya mo naman siyang patalsikin. Pag non-competitive, hindi mo siya mapatalsik, kaya bumababa ngayon yung efficacy. Okay? Malinaw ba iyon? So those are your different types of pharmacologic antagonism. Okay, so next, no? So tandaan natin na hindi lahat ng mga effect ng gamot sa katawan natin ay expected. So there are certain drug variations in the body, no? Such as your idiosyncratic reactions. So your idiosyncratic reactions, ito yung mga kunwari hypersensitivity reactions na hindi mo ma-explain based dun sa mechanism of action ng gamot. Or for example, you also have yung mga drug-induced na lupus, 'di ba? Na effects, no? Which is seen in yung tinatawag nating mga HIPs, no? HIPs. Ito yung mga drug-induced lupus erythematosus, no? Drug-induced lupus erythematosus. So H for hydralazine, no? Hydralazine. I for isoniazid, isoniazid. P for your procainamide, and your S for sulfonamide. So ito yung mga different types of idiosyncratic reactions natin, no? Related to your drug-induced lupus. Okay. We also have your tachyphylaxis. Pag sinabing tachyphylaxis, no, pag sinabing tachyphylaxis, this is a rapid tolerance or rapid development of tolerance to a certain drug, no? So kapag kasi sinabi nating tolerance, no, kinakailangan mo ng mas madaming amount ng gamot to achieve a certain effect. Diba? For example, yung coffee natin, when we're continuously exposed to coffee or caffeine in the body will alter the number of receptors, no? And when that happens, no? When that happens, your body would require more, okay, caffeine to achieve a certain effect, no? Kaya mapapansin mo pag lagi kang nagte-take ng coffee, pag kunwari, aabot ka sa point na nag-develop ka na ng tolerance na kailangan mong taasan pa yung dami ng coffee na kailangan mong inumin para ma-achieve yung certain effect. So those are some variations in your drug responses. Okay? So next slide, no? Let's just have a quick rundown of these questions. So try nyo answer na sa inyong mga seats. No? So the variable in the dose response curve that defines efficacy, ano nga yung efficacy natin? Diba? It's the maximal effect. This is your Emax, no? This is your Emax. Kapag sinabi naman nating dose response curve that define variable dun sa dose response curve that defines potency, sinabi ko to kanina, diba? It's your EC50 or your ED50, the drug, okay? The concentration of the drug that will reach 50%, okay? Next, type of agonist where efficacy decreases but potency remains. Again, efficacy. Bumagsak yung efficacy. Anong tawag doon? No? Anong type of antagonist? It's your irreversible antagonist. No? Your irreversible antagonist. Pag sinabi naman nating antagonist where the potency decreases pero yung efficacy remains the same, it's your competitive antagonist. Sabi natin, di ba? Kaya mo namang taasan yung amount ng drug para mapatalsik si antagonist natin. Next, number 5, it's your dose response curve change with an irreversible antagonist. No? Irreversible antagonist, ano mangyayari? Downward shift kasi bumagsak yung efficacy. Di ba? Number 6, dose response curve change with a competitive antagonist. Okay, pag competitive antagonist, ano nangyayari? Ma-achieve mo pa rin yung maximum, pero yung graph mo, mag-shift siya papunta sa right. No? And when your graph shifts to the right, your potency increases or decreases? It decreases. Bakit? Kasi kinakailangan mo ng mas mataas na dose to reach a 50% effect. Naintindihan ba yon? Okay, so those are your basic principles. No? Puntahan lang natin naman ang ating pharmacokinetics. No? Tapos na tayo sa pharmacodynamics kanina. So, basically, ang ating pharmacokinetics, puntahan muna natin yung solubility kasi a drug should be soluble first for it to be absorbed in the body, no? Or for it to cross certain membranes. Remember yung term na LUNA. Yung LUNA, no? LUNA means lipid soluble, no? If you're lipid soluble, sulat natin. Lipid soluble, okay? Uncharged, okay? If you are uncharged or if the drug is uncharged or if the drug is neutral, it can be absorbed. Bakit? Kasi yung katawan natin, no, yung mga lip membranes natin, they are made up of lipids. So if the drug is lipid soluble, makakapasok siya. If it's unionized or wala siyang charge, kung wala siyang charge na positive or negative, makakapasok siya. Pag neutral siya, makakapasok din siya doon sa lipid membrane natin. Kasi wala siyang kasi neutral yung ating membrane, yung lipid membrane natin. So you have to keep this in mind, no, yung LUNA na tinatawag natin. Next, park this muna in your mind, no? So punta tayo sa permeation. Pag sinabing permeation, these are, we have different types of permeation. Basta permeation is the process by which a drug enters a certain system by passing through a membrane, no? So meron tayong different types of permeation. You have your diffusion, meaning walang energy na kinakailangan dyan. Kaya lang niya mag-pass through the membrane. Okay? Carrier-mediated, meaning you need a carrier for you to transport, okay, a certain drug towards the other end of the membrane, no? And endocytosis and pinocytosis naman, yan yung type of permeation na kinakain niya yung drug para makapasok, no? It engulfs the certain drug, no? I-envelope niya with a lipid membrane, papapasukin niya, no? Doon sa loob ng cell. So these are your different types of permeation. So let's discuss first yung diffusion. Pag sinabing diffusion, it's the parang non-energy requiring siya na way of passing through the certain membrane, no? It's defined by your Fick's law of diffusion, no? Your Fick's law of diffusion is parang governed by this equation, no? Your C1 minus C2 times your permeability coefficient over the thickness times the area. Ano, medyo toxic siyang pakinggan. Pero imagine niyo lang siyang ganito, no? So, for example, no? Ang concentration 1 and concentration 2 kasi, no? Yung concentration 1 and concentration 2 defines yung difference in the amount of drug doon sa one side, no? So kunwari, meron kang 10 drugs doon sa other side at meron kang 2 lang dito sa kabila, no? Yung difference in concentration between the two is 10 minus 2, no? Ibig sabihin, that's 8, di ba? That's 8. Ibig sabihin, guys, no? Mas mataas yung rate of diffusion kapag mas different yung concentration between the two sides of the membrane, no? Ikumpara natin kapag ka 10 din, or kunwari, sige, sabihin natin 9. Ilan na ba to? Kunwari 9 dyan. Ang concentration gradient mo dyan would be, ilan nga? 10 minus 9 is 1. So, sino ang mas mataas? Si 8 o si 1? Siyempre si 8, no? Pag mas mataas yung number, no, mas mabilis yung rate mo. Diba? So, that is your concentration gradient. Next is your permeability coefficient. Your permeability coefficient, imagine niyo siya as parang inherent capacity ng isang substance para makapasok. So it's also affected by your lipid solubility, no? Your lipid solubility. Now, if the drug is more lipid soluble, mas permeable siya. Mas kaya niyang pumasok. Hence, dito sa permeability coefficient, mas mababa yung permeability coefficient mo if you are water soluble. Naintindihan ba? So therefore, kaya siya nasa numerator, okay? Kasi pag mas soluble ka, okay? Pag mas soluble ka, pag mas lipid soluble ka, mas mabilis yung rate. Okay? Naintindihan? So we have now two concepts na nasa numerator. You have your concentration gradient and your permeability coefficient. Next, puntahan natin yung last na nasa numerator, si area. Kapag mas makapal si area, no? Mas malawak si area, ayan, kunwari lumawak si area, ang nangyayari ay mas bumibilis din si rate. So therefore, may tatlo kang principles that increase the rate. Ano nga yun? Yung lahat na nasa numerator mo, which is yung concentration gradient, yung permeability coefficient, and yung area. Mas malawak na area, mas madaming area para pumasok, mas permeable ka, mas makakapasok ka, no? Mas malakas yung concentration gradient or mas malaki yung difference ng dalawang concentration, mas makakapasok ka or mas mabilis yung rate. Kaya ngayon nasa baba si thickness, okay? Si thickness which is inversely proportional, no? Sa rate kasi bakit? Pag mas makapal si membrane mo, mas mahirap pumasok, di ba? So therefore, no? Your thickness is at the denominator. So i-visualize nyo lang siya na ganun. Hindi nyo kailangan i-memorize yung Fick's law of diffusion, no? Mas madali nyo siyang ma-understand, no? So ngayon, pag tinanong kayo, pag mas makapal yung membrane, mas mahirap pumasok. Pag mas permeable ka, mas madali ka makapasok. Pag mas maikli mas maliit yung area, no? Mas kokonti yung rate. Pag mas malaking area, mas bibilis yung rate. Okay? So that's your fixed law of diffusion. So ang gusto natin, malawak, no? Malawak tulad nito, manipis tulad ng pinakita ko dito, no? Manipis siya, di ba? And dapat mataas yung concentration gradient, no? Ibig sabihin, mas madami yung nandun sa other side kumpara dun sa other side. Kasi ang body natin, ang gusto niyan, mag-equalize. So ngayon, ang goal niya, mailipat yung iba sa kabila para mag-equalize siya. So ngayon, gugustuhin ni body na mag-equalize kapag mas iba yung concentration mo from one side to the other side. Malinaw ba yon? Okay, so next na i-discuss natin under your pharmacokinetics will be your acid dissociation and basis dissociation. Tandaan natin na yung mga different sets of drugs natin, they can be weak acids, no? Mostly weak acids or weak bases, okay? Yung weak acids natin and weak bases, kapag in-expose mo sila in an aqueous environment, they always dissociate, no? And yung dissociation na yon ay laging in equilibrium. The body will always try to achieve equilibrium kasi. Okay? So, now, no, tignan natin yung certain environment na ng mga different systems natin. If you expose an acidic drug, no, an acidic drug in an acidic environment, what will happen, no? So, ang acidic environment, madami yan H plus or protons in the body in the system, no? Acidic environment, madaming protons. And remember, 'di ba sabi ko, ang mga weakly acid natin and weak bases natin, nagdi-dissociate sila into its component electrolytes, no? Kunwari ito, okay? It's a weak acid. It will dissociate into A minus and H plus. So that's the normal thing in an aqueous environment. Okay? Ngayon, dito sa discussion natin, I'll draw a seesaw for you to imagine an equilibrium. So yung itong fulcrum na to, wow, physics. Yan, yung fulcrum na to denotes yung opposite arrow na nakalagay dun sa equation. Okay? Ang goal ni body ay mag-equalize yan, no? Or mag-equalize siya. It will always achieve equilibrium. Pero kunwari, yung drug ay inilagay mo sa isang acidic environment, no? Sabi natin, masyado madaming protons. Ang gagawin niya, no? Si protons, ililipat niya dun sa other side of the equation to form more of your H+. Kasi masyadong mabigat yung other side. So what it does is, ilipat niya dun sa kabila, no? To form more of your kung ito yung products, di ba? Ito yung reactants. To form more of your reactants para mag-equilibrate siya. So, di ba, this is your Le Chatelier's principle. Kung naalala nyo dun sa basic chemistry ninyo. Now, kapag ang goal ng Le Chatelier's principle is mag-equilibrate, di ba? Kung madami kang product, gawa ka ng reactants. Kung masyado ka madaming reactants, gagawa ka ng product. So kanina, in acidic environment, masyado ka madaming product, masyado ka madaming H+, di ba? Ngayon, ilipat mo sa other side of the equation to form more of your reactants. Hence, you form more of your HA, no? Now, yung HA na yan, di ba, kung makikita nyo, wala siyang charge. Neutral siya, okay? Mas maa-absorb siya ng body. Kasi di ba, tinuro ko yung Luna earlier. Luna, di ba, lipid soluble, uncharged, neutral, they will be absorbed. Hence, an acidic drug in an acidic environment will have more absorption. Naintindihan ba yon? Okay. Next, if you expose an acidic drug in a basic environment, no? A basic environment will have low H+ concentration. Ngayon, nag-tilt ulit yung equation, no? ng equilibrium natin. Ang gusto natin ngayon, dahil masyadong mababa yung products natin, di ba, products natin, mag-donate ka naman dun sa other side. Ngayon, si HA mo, no, magdi-dissociate siya to form H+, no? Ilipat niya dun sa other side of the equation. Ang nangyari, bababa yung concentration ni HA mo. At dahil bumaba yung concentration ni HA, bababa din yung number na maa-absorb, di ba? Hence, an acidic drug in a basic environment will cause lesser absorption. Okay? Kaya ang gusto natin, an acidic drug should always be in an acidic condition para mas madaming ma-absorb. Naintindihan ba yon? Okay. Next, punta tayo sa basic dissociation. So, weak bases, no? Ito yung ano niya, equilibrium equation. So, kapag in-expose mo sila in aqueous solution, ganyan siya nagde-dissociate yung mga bases natin. Okay? Again, denote natin yung equilibrium by means of the seesaw. No? So, if you expose a basic drug in an acidic environment, again, acidic environment will have lots of H+, tilting the equation, di ba? Mas heavy dun sa product side. Okay? Product side, no? Ito yung reactant side. Reactant side. Ang gagawin ni body based dun sa principle ay ilipat niya to form more of your reactants. Okay? Ngayon, si reactants, sino yung reactant natin dito? Si BH. Mapo-form mo mas madaming BH. Okay? Mas madami kang na-form na BH. Okay? BH+. Pero, guys, tignan natin, no? Ang nangyari kasi dito, no? Si BH+ ay hindi naman ma-absorb. 'Di ba? Hindi naman siya ma-absorb kasi bakit? May charge siya. Correct? 'Di ba? By Luna principle, no? Hindi nakakapasok ang may charge, hindi nakakapasok ang may charge and hindi rin siya makakapasok if it's water soluble, no? Hence, a basic drug in an acidic environment will decrease the absorption, no? Mas bababa yung absorption niya kasi nagkakaroon siya ng charges, no? Ang gusto nating ma-absorb actually ay si B+. Pero kinailangan mo si B+ para mag-mix dun, 'di ba kanina nakita nyo yung mga H+ natin? Ito. Tingin kayo dito sa right side of the screen. Yung mga H+ natin pinalipat natin sa kabila. Nung lumipat sila sa kabila, isasama din nila si B to form your BH+. Ang bilis. Nangyari. BH+. Okay? Kaya bumaba din yung amount ni B. Nagets ba? Pero si B kasi yung drug na gusto nating ma-absorb kasi siya yung walang charge. Siya yung neutral, no? So, tignan natin yung other side of the system. If you expose a basic drug in a basic environment, no? Ang basic environment ay konti lang yung H+, okay? Ang gagawin ngayon, no, para mag-balance yung equation, magdo-donate si BH ng H+, no? Ayan, nag-donate siya, okay? Lipat niya yan saan? Sa kabila, no? Ililipat niya sa kabila para mag-equalize yung equation. Okay? Nung nilipat niya yung H+ sa kabila, syempre nagbigay din siya ng B, di ba? Nagbigay din siya ng B. Dumami ngayon yung B, which is your base, no? Now, increasing the amount of drug, the form of the amount of drug that can be absorbed, no? So mas tataas yung ma-absorb. So, ngayon, ano ang learning dito? Basic drugs in basic environment will increase the absorption of the drug. Kasi magpo-form siya ng mas madaming B na walang charge. Naintindihan ba yon? In essence, ang learning dito sa mga slides na to would be, okay, acidic drugs, mas ma-absorb in an acidic environment. Ang basic drugs, mas ma-absorb in the basic environment. Kailangan same environment sila. Okay, so that's the principle behind this one. Okay, so next. Punta tayo dun sa mga different pharmacokinetic processes. Yung mga different pharmacokinetic processes are the following: your absorption, distribution, metabolism, and your excretion. Let's start first with your absorption. Okay? Your absorption will depend on the route of the administration, no? And also depend on the blood flow na dumadaan dun sa area na yon, nung organ na yon, and also the concentration. Okay? Di ba? Diniscuss natin kanina na mas mataas yung concentration gradient, di ba? Kunwari ito yung lipid membrane mo. Pag mas mataas yung concentration ng gamot na nilagay mo, syempre mas onti nandun sa other side, mas mataas yung diffusion. So mas mataas yung absorption mo. And also, pag mas mataas yung blood flow, pag pumasok si drug, mamimit na niya si systemic circulation, di ba? So hence, distributed, nakapasok na siya agad sa system natin. And absorption is the process by which the drug enters the systemic circulation. Yun yung goal niya, ma-reach yung systemic circulation. Okay? And the route of administration will also affect the absorption of the drug. Okay? So, there are different routes of administration. Your oral, your sublingual, and buccal. Di ba? Your sublingual and your buccal will cause direct absorption to the systemic circulation kasi madaming blood vessels dito sa ilalim ng dila natin. Di ba? Your intravenous naman will have 100% absorption. Bakit? Kasi anong definition ulit ng absorption? It's the process by which you absorb a drug to the systemic circulation. Pero pag tinusok mo na siya doon sa systemic circulation itself, absorb na siya agad, 'di ba? 100% absorption. Pag intramuscular, no, this is a depot type of administration, meaning pwede kang magstay doon for a long period of time na slowly kang na-absorb ng body. Pag subcutaneous naman, ito yung mga insulins natin, 'di ba? Sa ilalim ng katawan, no? Ilalim ng katawan. Ilalim ng balat, no? So those are your subcutaneous route, no? Suppository naman, so dadaan sila dun sa mga rectal veins natin. Inhalational towards yung mga to achieve yung pag-beat niya dun sa mga receptors, kunwari sa yung beta receptors natin, no, yung inhalational drugs natin, and or topical. Yung topical natin, okay, yan yung mga drugs na inilalagay natin sa ating mga balat para ma-absorb sila on a local basis or pwede rin sila ma-absorb systemically, no? Ang term doon would be transdermal na, no? Hindi na siya topical. So topical versus transdermal should always be different. Okay? Topical, local area lang. Transdermal would be systemic circulation ang ma-achieve mo. Okay? So those are your different types of administration. Now, when we talk about absorption, we should know the term bioavailability. Your bioavailability is defined as is related, no? Or is defined by the area that is under the curve, no? Area under the curve. So yung bioavailability natin, the more na mas madami kang mas malaki yung area under the curve, mas bioavailable ka, no? So intravenous drug will have 100% absorption agad at the start, no? And is defined by this graph, no? And the area under the curve of your intravenous drugs, no, or intravenous route na drugs will have bigger area under the curve compared to your oral. Kasi yung oral natin, no, when you look at the graph, no, it will have a slow absorption first, tapos ma-reach niya yung peak, and then slowly it will be eliminated. So mas bioavailable ngayon yung ating intravenous drugs kasi mas mataas yung area under the curve nila. Okay? Ano ang clinical application ng ating bioavailability, no? One of the clinical application of your bioavailability is for us to know yung ating maintenance dose. Tandaan natin na ang maintenance dose is the product between clearance and your desired plasma concentration. Tandaan mo na you want to maintain a certain amount of drug in the body, di ba? Kaya tinawag na maintenance dose. Ngayon, yung maintenance dose, for you to know kung ilan yung kailangan mong ibigay na maintaining dose, kailangan alam mo ilan yung gusto mong ma-achieve na concentration. Kaya nasa numerator to, si desired plasma concentration. But you have to factor in gaano kadami yung naitatapon, no? Gaano kadami yung naitatapon sa body, which should be defined by the clearance, no? So kaya minumultiply mo si plasma concentration with that of your clearance. And if you divide all of that with the bioavailability of the drug, that is now defined as your maintenance dose. So later on, makita natin yung difference niya with another clinical application na topic, no? So ito muna, plasma concentration and the clearance all over bioavailability will give you the maintenance dose. And when you achieve the maintenance dose, no, ma-achieve mo ngayon yung tinatawag nating steady state, no? Kasi if you give the drug at repetitive times in a day, for example, every 8 hours, no? Kahit bumababa siya, no? Kahit bumababa yung level niya, no? Madali mo siyang maipataas ulit. So meron ka ngayon steady state na tinatawag. So nasa certain level siya na na-achieve niya yung ED50 or your EC50, or it's defined, di ba, as the concentration at which you achieve the effective concentration of the drug, no? So ayan. So that's your steady state theory. Okay? So next, tapos na tayo sa absorption. We now go to your distribution. For distribution, this is defined as the transfer of the drug, no, from the bloodstream to the organ. So kung kanina, di ba, yung absorption ay papunta sa blood vessel, no? Kunwari ito yung blood vessel mo. Yung absorption ay yung distribution naman ay papunta sa organ. So kunwari papunta sa liver, yan, or papunta sa mga muscles, no? Yan. So that is your distribution. So for distribution, it is affected by the following, no? Your organ size, no? Your blood flow, yung solubility natin, and your protein binding. Pag organ size mas malaki, syempre mas malaming na-distribute. Pag mas madaming blood flow, no? Well-perfused organs, remember, well-perfused organs will achieve higher tissue concentration sooner. Kasi madaming dumadaan na blood vessels. So mas madali mo silang ma-deliver to that certain area. Solubility, okay, of a certain drug will also define distribution. Kasi for example, brain is mainly lipid, di ba? Brain is mainly made up of lipids. Hence, lipid-soluble drug will concentrate more in the brain, no? Kaya na-affect yung distribution natin. And next, protein binding will also affect your distribution because in the blood, remember that the main protein is your albumin, and albumin always, no, parang it binds to acidic drugs. Now when it binds to acidic drugs, no, ang nangyayari dyan, no, dahil malaki ang albumin, hindi naman kayang pagkasyahin ni albumin yung sarili niya through the lipid membrane ng ating blood vessel. Kaya hindi siya na-distribute. So, higher protein binding will cause lesser distribution. Nagigets ba iyon? Okay. So, higher protein binding, lesser distribution. Okay. So, skill keeper lang. Sabihin niyo sa akin kung increase or decrease, no? More protein binding will lead to what? Increase, decrease. Decrease distribution. Pag mas lipid-soluble drug, mas increase or decrease yung distribution in a lipid, primarily lipid organ. Mas increase yung distribution, no? Lower blood flow will lead to decreased distribution, no? Higher blood flow, okay? Higher blood flow will lead to increased absorption. Absorption yung term dyan, ha? Okay. So, next term, let's discuss volume of distribution. Okay? Volume of distribution. Your volume of distribution, okay, is defined as the amount of drug in the body and the concentration in the blood. Okay? So again, para hindi kayo malito, nasa distribution topic tayo ngayon, ha? So, imagine niyo yung pink dito sa picture ay yung ating blood vessel, and yung green dyan is the yung mga tissues natin or yung extravascular compartments in the body. Okay? Your volume of distribution is the amount of drug in the body, which is seen here, over the concentration in the blood. No? So, if you have a drug that has higher, okay, higher volume of distribution, okay, dito muna tayo sa letter C, no? If you have higher volume of distribution, makikita nyo na mas madami yung drug, di ba? Kunwari, ito. Yung numerator mo. The amount of drug in the body, which is 200, kunwari, yung 200 na yan is 198 plus 2, okay, divided by 2, okay, will give you 200 divided by the amount that is in the blood, no? The amount that is in the blood, which is 2 lang. So ngayon, yung volume of distribution ng drug na ito would be 100 liters. Okay, 100 liters. So it's the theoretical amount na that will help you define kung nasaan yung certain drug, no? I-compare natin ngayon for drugs that have low volume of distribution. For drugs with low volume of distribution, di ba? Tignan natin ha, itong second picture, okay? Ilan dito sa, kunwari, 18 units daw nandun sa blood, 2 units nandun sa extravascular space, no? Ang formula ng VDI, di ba? Ang formula ng VDI, amount ng drug in the body. So it includes intravascular plus extravascular. So that's 18 plus 2, okay? Divided by concentration in the blood. That will give you 1.1 liters, okay? 1.1 liters. So therefore, this equation, no, is a visual representation that drugs with lower volume of distribution will have a higher chance that it is in the bloodstream. Bakit? Kasi doon sa equation natin, no, yung concentration in the blood mo is in the denominator. And if higher yung value ng denominator, ibig sabihin, mas bababa yung value ng volume of distribution mo. Kasi di ba, pag ito, ginawa nating 100, para kang nag-divide ng 1 divided by 100, mas lumiliit yung value ng VD. Compared mo, if mababa yung concentration in the blood, di ba? Pag kunwari, mas mababa yung concentration in the blood, which is the denominator, tumataas yung volume of distribution. Ngayon, ang konsepto nito ay, pag mas mababa si volume of distribution, si drug natin ay likely nasa blood. Pag mataas si volume of distribution, si drug natin ay likely nasa extravascular space. Hence, ang learning na gusto kong matutunan ninyo dito ay, no, yung drug natin, if it has higher volume of distribution, likely nasa peripheral yan. At kapag mababa ang volume of distribution, nasa blood siya. Hence, kapag ikaw ay nagkaroon ng toxicant, for example, and yung toxicant na yun have low volume of distribution, pwede kang mag-undergo ng hemodialysis para maalis yung drug na iyon sa katawan. Kasi bakit? Sabi natin, ang drugs na may low volume of distribution will always or will have a higher chance that it is seen in the intravascular space. Okay? Malinaw ba iyon? So, anong clinical application ng ating volume of distribution? Kung kanina, di ba, diniscuss natin yung maintenance dose, your volume of distribution will help us know the loading dose. Okay? Kanina, di ba, nakita na natin yung desired plasma concentration na nasa numerator and the bioavailability that is in the denominator. Ito, i-memorize nyo na to na ganyan talaga siya. Plasma concentration over bioavailability. Okay? But if you multiply this na nasa loob ng box with another value, no, such as your volume of distribution, it will give you your loading dose. Kasi, no, if the drug has higher volume of distribution, saan nga mapupunta yung drug? Mas sa extravascular space or nandun siya sa mga tissues, no? Hence, kinakailangan mo ng mas mataas na loading dose. Bakit? Kasi nadidistribute siya sa periphery. Ang gusto mo, di ba, ma-circulate mo siya sa buong katawan to have more effect, to have higher clinical effect, no? Pero pag ikaw ay you have a lower volume of distribution, this will pertain na yung drug ay nasa blood or nasa intravascular space natin, no? Kinakailangan mo lang ng lower loading dose. Okay? Ano nga yung difference ng loading dose versus your maintenance dose, no? Yung ating loading dose kanina, no, will be multiplied by your, di ba? Pinakita natin yan earlier dito. Will be multiplied by your clearance, yung maintenance dose natin. While your loading dose, it's multiplied by your volume of distribution. Okay? So, clear ba iyon? So, let's now go to another concept in your pharmacokinetics. You have your metabolism. Your metabolism will involve yung termination ng action ng certain drug or in some cases, no, activation of certain action of a certain drug, particularly your prodrugs, no, and also the excretion of these drugs, no. Pag sinabi nating metabolism, no, ang gusto na ang main organ na involved dito is your liver, no? Kadalasan liver kasi nandiyan yung mga enzymes natin for metabolism. So when the drug passes the liver, usually ang metabolism, ang goal niyan ay maging water soluble yung gamot natin para mas madali siyang ma-excrete, no? And if the drug is a prodrug, no? And it undergoes metabolism through the liver, no? Mas na-activate siya, no? Compared mo sa usual drug lang na kunwari hindi siya prodrug, ang goal ng metabolism is to terminate the action, no? But if it's a prodrug, it activates that certain drug, no? But ang goal ng metabolism is for it to be water soluble para mas madali siyang ma-excrete. So as you can see here, di ba? You have to make ang goal niya is to make it more polar for it to be excreted, no? So there are certain types of reactions, no, in the body that makes the drug more polar. So itong and it's defined by the following: yung hydrolysis, oxidation, redox reactions such as your reduction and oxidation, and your deamination, no? Ito yung mga phase 1 reactions natin. Your phase 1 reactions are also known as your functionalization reaction, while your phase 2 reaction are also known as your synthesis or your conjugation reaction. Bakit siya tinawag na conjugation reaction, no? It conjugates it to certain molecules, no, that makes it more water soluble, no? Hence mas madali siyang maitapon from the body, no? So okay. So next, puntahan muna lang yung phase 1 reactions. So your phase 1 reactions are mainly involving yung redox reactions natin. And yung enzyme na involved dito sa mga redox reactions natin, you have your cytochrome P450 enzyme, no? It's the major enzyme na nakikita sa ating katawan that is involved in metabolizing the different drugs that we take, no? This enzyme can be yung function nitong enzyme nito can be altered by different drugs. Ito yung tinatawag natin na enzyme inducer and enzyme inhibitors, no? There are certain drugs that induce your cytochrome P450 enzyme, no? And there are certain drugs that inhibit your cytochrome P450 enzyme. Drugs that induce, no, your cytochrome P450 enzyme involves the following, no? Yung PRC, G, aral na. Okay? Kasi 'di ba, parang lang ma-imagine niyo, PRC, 'di ba, board exam. So ayan, kailangan mong ma-induce na mag-aral, no? PRC, phenytoin, rifampicin, carbamazepine. G as in game, no? Game to aral for griseofulvin. Aral na, well, aral, alcoholism na chronic. Okay? Alcoholism na chronic. Okay. Next, yung ating mga inhibitors. Inhibitors are defined by your sickfaces.com. No? Sickfaces.com is a mnemonic ever since before pa, and it stands for the following, no? Sodium valproate, isoniazid, cimetidine, ketoconazole, yan, and the rest of the drugs that are here. Pero ang important to remember na hindi nyo dapat makalimutan ay yung chronic alcoholism and acute alcoholism. Pag chronic, that's an inducer, no? Inhibitor if it's an acute alcoholism. Okay, so the rest are for you to memorize here. But in summary, it's parang ang mnemonic dyan would be your sickfaces.com and your PRC G aral. Okay, so next, punta tayo sa ating elimination. So ang elimination, no, it's an umbrella term for metabolism and excretion, no? Kasi ang elimination, ang goal niya is mapaalis si drug sa body, no? Make it more polar for it to be eliminated. And metabolism, as earlier, no, na-discuss na natin, is a form of elimination. And excretion is also a form of elimination wherein the body then excretes, no, based on the term, no? Ilalabas niya sa bile, ilalabas niya sa ihi, or ilalabas niya sa pupu, no? Okay, so sorry naputol, no? So there in elimination, there are two types of orders. No, we have your first order elimination and then your second order of elimination. No, pagka sinabing zero order of elimination. So pag sinabing first order elimination, ang nangyayari dito is that the rate is half every time, no? A certain time is reached, no? For example, no, during the first half-life, ang rate of elimination niya is 5 units per hour, no? Pero pag first order elimination, sabi natin, it's decreased by half, no? So therefore, kunwari, from 5 units per hour, nangyayari, anong 50% ng 5? It's 2.5. Okay? And then on another half-life, no? On another half-life, yung rate of elimination niya is, again, decreased by 50%. So ang nangyari, 1.25 na lang yan, units per hour. I-compare mo siya sa zero order of elimination. Pag zero order of elimination, the rate of elimination per half-life is constant. No? Ibig sabihin, no, 2.5 units per hour. On the next half-life, it's still 2.5 units per hour. Naiintindihan ba yon? Up until maubos siya sa katawan natin. Example na mga ito are your aspirin and your alcohol. Okay? Aspirin and your alcohol. Okay? So anong clinical application nitong ating elimination? So it helps us know kung ano yung clearance ng drug sa body. So the rate of elimination divided by your plasma concentration will help us determine the clearance. And the clearance, as mentioned a while ago, will also help us know yung ating maintenance dose. Diba? And ano nga ang difference ng maintenance dose dun sa loading dose? Diba? Sabi natin, diba ito ay yung constant, diba? And if you multiply it to the clearance, no, you get the maintenance dose. Your loading dose, no, the difference is ito clearance, ito volume of distribution. And as you can see, ano yung similar sa kanila? This one, no? Desired plasma concentration over bioavailability. It just differs by the yung kung ano yung certain parameter that you multiply it with. Knowing the loading dose, no? You have to know the volume of distribution. Kasi di ba, pag mas mataas sa volume of distribution, mas nade-distribute siya and kailangan mo ng mas madaming loading dose kasi nade-distribute siya dun sa certain organs, nagsistay siya doon. No? Pero kapag ka nasa blood, by which a lower, it's defined by a lower volume of distribution, kailangan mo lang ng lower loading dose. Kapag maintenance dose naman, you multiply it by the clearance. Okay? So, yun. So those are your pharmacokinetic parameters. So next, punta tayo sa ating drug evaluation and regulation. Remember that before we release yung different drugs natin, you have to undergo several studies, and one of them would be your animal studies. So these includes yung mutagenesis, no, and the carcinogenesis test and teratogenesis. Pag sinabi nating mutagenesis, this is the process by which we know if there is an alteration in the genetic sequence of the certain organism. Pag carcinogenesis naman, it is the capacity of a certain drug that to cause tumor, no, increase proliferation ng mga certain cells. Pag teratogenesis naman, it's the term by which there is fetal malformation doon sa baby na nasa tiyan ng organism na iyon. So your mutagenesis can be done by the following test. Yung Ames test, no? Yung Ames test, ito yung na gumagamit ng salmonella, no? Salmonella to determine if there is a mutation in the genetic sequence of or if the certain drug would have a genetic parang kaya niyang i-alter yung genetic sequence ng organism na yon, no? And also your dominant lethal test. Your dominant lethal test will involve the use of your certain rodents, no, for it to see kung meron bang certain malformations or genetic changes dun sa organism. So, yan. Yung carcinogenesis naman, it's the capacity of your drug to cause carcinogenic parang proliferation of more cells. So for example niyan, yung mga nitrosamines natin na makikita doon sa mga tocino, no? Kung sino mahilig ng tocino dito, these substances are known to be carcinogenic. And yun nandito sa picture na to, yung from your aflatoxin, no? It can also cause your liver cancer, no? Your which is a form of cancer that can be seen when nakakuha ka ng mga carcinogenic from the aflatoxins, no? So teratogenesis, so these are some fetal malformations lang that you can see in the babies of your different organisms. So for example, sa humans, ayan, or sa animals, ayan. So that's teratogenesis. So as you can see, no, dito sa sa ating picture, ito yung Epstein anomaly as seen in your lithium, no, and yung ating mga drugs that can cause enamel problems such as your tetracyclines, no. So yung next na ipapakita ko dito is just a quick picture of the different teratogens that are commonly asked in the board exams, no. So, yan yung mga different studies natin, animal studies. There are also other studies that involve testing kung ano yung effect niya sa pregnant na mga subjects natin. So, we have 5 classes of reproductive studies, no? So, we have your class A, by which sa humans ay safe siya, no? And sa animals ay safe siya, no? Better to understand first yung class A kasi safe siya in both, no? And better to understand D and X first kasi sila yung madaling ma-memorize. Si X, no? Drug class X, sila yung mga risk outweighs the benefit, no? Itong mga to, meron talaga siyang unsafe studies in humans and animals, no? Pero ang difference niya with D, ito, kahit alam mong unsafe siya sa both, no? In some instances, pwedeng benefits would outweigh the risk pa din, no? Pero, well, it's still unsafe. So, parang clinical judgment na nung doctor if we still have to give it or if it's life-saving, can we give it kahit na mataas yung risk. Okay? So, yun yung difference silang dalawa. Now, your B and C, dito madalas na hihirapan, no? Pero, yung C natin, no? Yung C natin, as you can see, you have no studies in humans. And in animal studies, pwede siyang wala ring study or unsafe, no? Ikumpara natin siya sa class B, no? Sa class B, pwede siyang walang study, no? Pero safe pa rin naman siya sa animal. So probably it's safe, no? Probably it's safe kaya siya class B. Yung isa naman ay safe siya sa humans, pero may unsafe studies sa animals, no? So, ibig sabihin no, meron ka pa rin parang at the back of your mind, hala kung sa animal studies ay unsafe siya, kahit na-proven siya na safe sa humans, baka may posibilidad na maging unsafe pa rin siya sa humans. So, kaya siya class B drug lang. Okay? Again, when you memorize this, memorize class A first, memorize class D and X, and then yung no studies would fall under C, no? Pero yung isa would fall under B, pero dapat meron siyang safe animal studies. Okay? So that's how you memorize this table. Okay? And in the drug development of our different medications, no? Makikita natin na kailangan pumasok muna siya as a lead compound, no? Tapos kailangan siya mag-undergo ng animal testing to know kung yung efficacy niya, yung mga safety issues niya, no? And pag pumasok siya sa animal testing, dun lang papasok yung clinical studies natin. Ito yung mga clinical trials natin. And we have 3 clinical trials. Pag phase 1, no? Ang tine-check mo dito is it safe, no? Kaya ang subjects mo dito would be normal, healthy na mga individuals. Kasi ang gusto mong malaman, safe ba siya? No? Phase 2, does it work? No? Does it work? Or ang tinitingnan mo dito is efficacy. No? The efficacy. Hence, ang phase 2, ang mga subjects niya ay patients na may sakit. Kasi paano mo malalaman kung effective siya kung walang sakit yung patient na yon. And next, yung phase 3 naman, ito yung mas malaking clinical trials, no? Ang involvement dito is a double-blind studies, no? A double-blind study na kung saan halo-halo na yan. Meron syempre kailangan merong meron sila ng condition, no? Pero papasok dyan kung meron silang other comorbids, mga ganyan, and other factors na kailangan mong ma-consider before giving the certain drug. So dito, safety and efficacy na yung tinitignan sa phase 3. And phase 4, this is your post-marketing surveillance wherein nailabas mo na yung drug, no? Nailabas mo na yung drug sa market and titignan mo kung safe pa ba sila or hindi. Kaya dyan yung role ng FDA natin, no? Wherein kapag kunwari yung drug, nagkaroon siya ng certain reaction to a certain patient or certain amount of patient, no? Pwede siyang ma-recall from the market. Okay? And tandaan natin, dahil sobrang tagal ng development ng gamot, no? Tandaan, makikita nyo dito sa baba, it takes around 20 years of ang tawag dito? Yung patent mag-expire lang siya after 20 years kasi syempre kailangan mabawi nung ano tawag dito nung clinical pharmacy nung clinical ano tawag doon? Company, no? Clinical company yung ginastos nila for the past years in developing the drug, no? Kaya bawal muna magkaroon ng generics, no? Pero once the patent expires, the generics become available. Okay? So I think that's it for the basic pharmacology muna for now. Okay? And then we'll go to the next topic which is autonomics. Now for this point, no, I usually ask my students to take a break, no, before starting the next the next lecture. So pause muna, take muna kayo ng break, kumain kayo, tapos balik kayo. Pero wag matagal na break, okay? So see you in the next set of slides.